Welcome to a town hall meeting. I want to start by just describing what we want to do today. We'll start with some quick introductions. We wanted to talk about three main things today. Some things we wanted to celebrate. We wanted to do updates on our clinical and strategic planning. And third, do some updates on the staff satisfaction survey and the wage and benefits plan for next year. And hopefully allow plenty of time for Q&A at the end. As you'll notice, we're being taped today because we want to make this available for the rest of the staff. So over the coming week, we'll make that posted on 411. I want to mention today that this is only the second day that we're using the renovated AV equipment within Huvos. So hopefully you're impressed that we've come up with a much better system than we had. This is due to a very grateful patient that had a relationship with a physician who the patient felt motivated to give a gift that would enable us to do better education for the community, patients, staff, and trainees. And this is a great space to enable that. And so we're not quite done, but we will be over the next month in terms of a few more changes to the lights and the control system. So we'll see how it works today. So I want to start with introductions. We'll have the leadership team introduce themselves.
Judy Hayes, Chief Nursing Officer.
Vinnie McDermott, Finance.
Edliston Craftman, the Vice President.
Susan Dempsey, Vice President.
And O'Neill Britton, our Chief Medical Officer, is at an off-site meeting today. Also wanted to show some pictures. If you've heard the names of some of our leaders over the last 3 or 4 months who have joined, we're really happy to have these folks on board. Scott Chazelle is our new Chief of Medicine, started in July, full-time. Brandon Earp, who has been at the Faulkner for several years as an orthopedic surgeon, started as our Chief of Orthopedics in May. And David Pilgrim, who has also been on campus as a clinical neurologist with Atrius, is now splitting his time between Atrius HVMA and Brigham Faulkner and is our clinical chief of neurology here on the campus. And then most recently, Calvin Brown has started as Associate Chief of Emergency Medicine, working with Rick Larson and Renee as part of the leadership team in the ED. And then finally, Lisa Cole is joined as the Associate Chief Nurse for Practice and Innovation as part of the nursing leadership team. So very exciting news today that we can announce about a hot off the press award from the Joint Commission. We have been notified that for the second year in a row, the Faulkner has been recognized as a top performer in quality measures. And even more exciting is that the Faulkner is the only hospital in Boston that again this year has been recognized and the only Partners hospital that has gotten this honor. So I think we should give ourselves a round of applause. This award requires that for the key measures that we're working on, includes heart failure, surgical care, pneumonia, et cetera, that we maintain a 95% compliance rate with doing the right things consistently over time. And this represented the performance during 2011. So it's a real testament to our continued dedication to keep ourselves as close to perfect in terms of delivering the right standards to patients as possible. So I really want to congratulate and thank folks for that. And we continue to get several other recognitions over the last 6 months. We want to make sure that folks are aware that we're going to have our first ever Faulkner Community Health Fair, and that's going to be on Saturday, November 3rd from 10 to 12 here on campus. It's going to actually start with a walk through the Arboretum at 9 a.m. that same day. And the health fair has several different components to it. There's going to be a piece around healthcare screening, so kind of the typical blood pressure, weight, mammograms being available that day. There'll be some health educational sessions on different topics. We'll have some ways that we can highlight some of the newer clinical programs. So for example, the robot obstetric ultrasounds, which is a brand new service that's going to launch in the next month. And we'll have an opportunity to show folks some of the newer spaces on campus, particularly because a lot of the things will be down on the first floor. So we'll be able to highlight the Takelet Center, the Weiner Center, and maybe even some of the ED renovations. So I think it'll be great for people that haven't necessarily been on the campus to see some of this new space. So if you can help advertise this, it would be really helpful, posting this in all the departments, trying to talk it up with patients and families, and then trying to either participate or attend yourself. I wanted to show some pictures of a few of these spaces. This is the Weiner Center for Preoperative Evaluation. I think this has been a great enhancement. It certainly is a beautiful addition to the main pike, if you will, down on the first floor, as well as the adjacent radiology waiting space. We're a couple months into a 6-month phased renovation of the emergency department. And I think you can see in this comparison, this is an old emergency department bay, and this is what the new bays will look like. I think this is quite a facelift, quite an upgrade of the environment. And we also have already completed the central core workstations or work areas for all of the providers. And I think this is a much greater, more efficient, kind of team-based setup down there. So this will continue in a phased way through the end of December. And then finally, hopefully you've noticed we've tried to make some enhancements outside along the Allendale in terms of a new fence and completely new landscaping. Deb and Danny and folks have done a great job, as always, with the landscaping, so it's been beautiful to see that this summer. And then most recently, we made some changes to the back entrance on the 3rd floor. So I want to thank Rudy and Paul and Susan and a team that's been working on that. This is certainly the first point when many people come to work every day, so we wanted to try to make that a more positive, bright experience for folks to start their day. I wanted to just make a few comments about the healthcare reform legislation that was passed in Massachusetts. We've had 2 major landmark things that happened in the last 2 or 3 months. First was that the federal healthcare legislation was upheld by the Supreme Court, and it's still, the impact of the healthcare reform is still kind of working its way down to providers in the health system. And secondly, that Massachusetts passed another landmark set of legislation. And this was on the very last day of the legislative session and then signed by Governor Patrick on August 6th of this year. It's a 350-page document, which in many ways tries to tackle several problems in the state. It also essentially reorganizes the bureaucracy for healthcare at the state level. For example, DPH and some of the other agencies. So it's a really interesting, complex bill. But on this slide, we were just showing 2 or 3 of the most important points for hospitals, providers like ourselves. Probably the most important, and this was the biggest intent of the bill, was in 2006 when Massachusetts accomplished universal health coverage and have been able to get the insured rate from maybe 85% of people all the way up to now 99% of people in Massachusetts having some sort of health insurance coverage, a great accomplishment. But left unaddressed was, how do we actually pay for that? And how do we bend the cost curve for the total amount that we're spending on healthcare? Insurance premiums continue to go up at an unsustainable rate. So the first part of this bill is trying to set a target to control the growth of health costs over the next decade. It's anchored to what they're calling the gross state product, and that's essentially a little bit more than inflation at around 3.5%. And so for the next 5 years, the target is to only grow at 3.5%. And in the subsequent 5 years, it's even more aggressive to keep it down to 3% growth per year. And so that's an ambitious target. When you think about just a salary increase from 1 year to the next of 2%, or the cost of inflation for everything that we use, just inflation is at about 3%. And so that's not accounting for anything within healthcare in terms of increased utilization, new technologies, new drugs, everything else that's part of increased cost. So this is quite a challenge for us and for the state. The second part was something that specifically impacts partners. And this was an assessment fee on a very small number of providers in the state. It's for partners, it's about a $50 million one-time fee paid over 4 years for the insurers, it's about $160 million over those 4 years. That amount of money, that $200 million or so, is supposed to be used for three purposes: to help a small set of the most distressed community hospitals in the state, to support an increased number of prevention wellness programs, and then to accelerate adoption of electronic records for those hospitals that have not been able to do that yet. There's a component which is encouraging the formation of more accountable care organizations. Accountable care organizations are groups of providers, particularly hospitals with physician groups, non-acute settings, managing a population of patients over time and eventually assuming risk for those patients. So they've created standards for what constitutes an ACO. And then importantly, they're going to be directing more state business, whether that's Medicaid or state employers, into those types of products. And finally, there was a component that they were trying to prevent systems from contracting as a system. And obviously, this would have been really bad for partners. So instead of partners having one rate for all of the facilities or one contract, it would have been each hospital doing their own. And so that unfortunately was not part of the final legislation. So when you think about the ramifications of that legislation, plus everything else that we're doing with Medicare in terms of being a pioneer ACO and our contracts currently with our commercial payers, those contracts all share some things in common, which is we have increasing accountability for quality measures. In some cases, for our actual patient satisfaction data, like the HCAHPS inpatient satisfaction survey. And we're now increasingly accountable for the trend of cost growth for those patients. So this, I think, really represents the work that we have to do over the coming years. We have to be doing work in all three of these buckets. And together, this represents healthcare value. So when we talk about the value equation, these are really the three parts of that equation. So shifting gears now to the, there has been a very turbulent environment. What are we doing internally to position ourselves for success going forward? So we'll share an update on the clinical planning, what we're calling some key enablers that we're changing, and then a little bit about master planning. So Pardon Kinney and Mairead Hickey and a group of leaders from both Faulkner and the Brigham have been leading a very aggressive clinical planning piece of work for the last year. And one of the first things that we did last fall was to really put a stake in the ground around guiding principles for the Faulkner campus. What are the types of, as we think about different opportunities, what are going to be our guideposts, if you will? And so just to remind folks, the idea of Faulkner is really important in this entire spectrum or continuity of care, and that we can provide an opportunity to provide the right care in the right place for patients. When we do that, we should be able to maximize the value for patients. Going back to that equation, we have great outcomes and a great experience, and hopefully we can do it at a lower cost structure. And we need to preserve that lower cost advantage. We historically have had a great commitment to education here, and it's a very strong feeling that we want to continue that as part of our mission. And we are a community hospital for the 4 or 5 communities directly around us who see us as their primary, secondary care provider. And we're certainly not going to abandon that part of the mission. So when you translate that into actual what clinical programs specifically are we going to do, the programs really fall into 3 categories. So the first is what I would call population management. And that really starts with a realization that we need to be growing our own primary care base. Historically, we've been more dependent on outside primary care groups or referral groups. And so we have to get a coordinatus or group of our own primary care patients. And as you grow that, then there'll be demand for all these other secondary care services. And so we're thinking about what programs should we be creating here or elsewhere in the network to support that. Historically, we've had a strong tradition of some medical subspecialty programs, particularly neurology and the Graham Headache Center as being an example, the renal programs, and since 2005, the Dana-Farber oncology relationship. And so we have opportunities to really build off of those great foundations. And then finally, we have invested a tremendous amount in our surgical infrastructure and our perioperative services over the last decade. Having 16 ORs is a huge infrastructure for a community hospital of our size. That has allowed us to create some really great subspecialty programs. And the plan going forward is to build on those and add some new programs. And I'll talk a little bit as one example, the Joint Center, or in some cases, return, like vascular surgery, which at one point was done here, maybe bringing that back to the campus. And so I think all three of these represent great opportunities. We thought what we'd do is just show you one example in each of the three categories, kind of as evidence that we are making forward progress and there's a tremendous amount of action going on. So within primary care, if you look at the bottom here first, to be very specific around what is growing within primary care and how's it going to impact the Faulkner, there are three major practice changes that have occurred. The first was a new Norwood practice opened in June of this year. There were 4 primary care providers, plans to add an additional 2. You can anticipate that a good part of the business, the hospital-based business from that practice would come to the Faulkner. The HMA practice that's on this campus has decided to be integrated and come into the Brigham primary care practice, and that's going to take effect in January of 2013. And then finally, the Foxborough primary care practice, which has been very successful. It's in a market that has an under penetration of primary care physicians. It's going to actually double in size in May of 2013. And we've been seeing a good amount of referrals from the Foxborough Center to the Faulkner campus. And so on the top is showing something different, which is when you have Brigham primary care physicians and those patients then need general medicine admission in the hospital, well, obviously many of those patients could either be at the Brigham or at the Faulkner, and the care would be very similar. And we're just showing the breakdown over time. And you can see 5 or 6 years ago, we were at only 20% of those patients being in Faulkner beds. And that has really changed to almost half of those patients now being at the Faulkner instead of at the Brigham. So I think this is the best diagram to show right care in the right place and actually turning that phrase into something that's very real and meaningful. For neurology, as an example, they're really thinking about 3 pieces. So one of it is the inpatient program. And to help bolster that, as I mentioned, we've hired a chief of clinical neurology. One of the first things that he's going to be working on is to improve our inpatient and ED neurology consult coverage, and also the education of the trainees on the medical service around neurology patients and conditions. On the ambulatory side, they've already expanded their practice capacity by adding some physicians and sessions in these areas of neurology, pain, headache, epilepsy, and sleep, with a desire to expand even further once we could provide some more space. And then finally, around the procedure part, we already do some things like EEGs and EMGs, and we're going to be launching in October a brand new test called an autonomic lab. This is a good example where Faulkner is going to be able to offer this test for the first time within the partner system. There's no other hospital or partners facility that's offering this. So it's a very nice example of Faulkner getting out in front and being able to offer something unique. And then finally, and other things we're working on, like the ability to do infusions for acute migraine headaches in our infusion center, the OPOU. And then finally, as an example of a surgical program, we're working hard on the concept of a joint center. When we say joint center, we're really talking about knee replacements, hip replacements, and shoulder surgery, shoulder replacements. And primarily talking about primary or first-time surgeries for patients that are in pretty good condition and not with the most number of comorbidities. And so, which means that some of those patients would be done at the Brigham, but probably 70% of the patients could be done at the Faulkner as part of such a program. So the vision of that is to, first of all, create a pathway, a patient care pathway around that entire episode. So when you are starting with the first decision that you need to have a knee replacement for example, and what are all the components in terms of preparation, education, the actual surgery, and then recovery outside of the hospital. We want to think about this in a very holistic continuum of care way. And then physically, how do we take care of these patients in an environment that has some enhanced features like some on-unit physical therapy, for example, or better family patient spaces. And so we're hoping to design an enhanced physical space that we could base within our surgical programs on the 7th floor over time. Short of a major renovation, we're hoping we can do some short-term changes so that we could get this going sometime in the next year. Now, moving on to some of the more strategic enablers, we identified a list here that we've been working hard on. The first was that if we're going to make substantial investments in these programs and in the campus, we really did make sure that our governance was aligned. So Mary Ann Tynan, our board chair, has led some great work in getting the two boards, the Faulkner and the Brigham, aligned and integrated so that we now have a common membership on those two boards. And we have common oversight committees for finance, compliance, and our quality functions. So I think it's been a good transition over the last year. I'll talk a little bit about branding plans going forward, a major decision around our IT strategy. We are going live in October with an integrated credentialing process for physicians. This is going to be a major step forward. To date, it's been a very disjointed two separate processes for any providers that wanted to practice between the Brigham and the Faulkner. And our intent going forward is to have one single integrated process and one approval process completely synced up in terms of timing. And so there's been an amazing amount of work over the last 3 months to get that. We just met with the medical staff triennial meeting last night, and they were very supportive and positive about this and voted full affirmation to move forward. So we're looking forward to that. And then in terms of master planning, hopefully this summer you notice some things going on campus. We were doing some testing in the back in front of the campus just to see what's the structure like underneath the ground. Do we have a ton of pudding stone rock that really prevents easy construction, or is it easier to do? We're doing a lot of surveying around the overall site. We're doing traffic studies. I noticed today it's the first time that there's a big backup outside in the back again, so it's a sign that we're starting to ramp back up for the fall. But we have a traffic and parking problem, and there's no easy solutions, so we're really trying to use a parking consultant to think through what our options are. And then looking at the age of the facilities, some of the infrastructure issues. The building was built in 1975, so it now means that we're 35 years old. So at this point, there's some systems issues that we have to think about. And then how can we, related to these programs, how can we think about adding some incremental space either within the existing structures or adjacent to the structures on the campus? And so all of that is wrapped up in what we're calling a master planning exercise, and we hope to have a first pass report out of that by the end of November. So talking a little bit more about branding, we thought we'd just show you the evolution of the logo over the last 13 years, sorry. And I think this really is helpful. Obviously, back in the late 90s, we had the Faulkner chevron with the tradition of caring. Several years later, the logo changed with the Brigham Shield, kind of Brigham Women's Healthcare over here. Several years later, we were trying to emphasize the relationship with a bigger font. And I think this shows that as the relationship has matured and as the integration between the Brigham and Faulkner has progressed, we're trying to reflect that. And so it was kind of the natural evolution as the last step to formally change the name of the hospital to Brigham Women's Faulkner Hospital, which is effective October 1st. And hopefully this will convey better to the public the nature of the relationship between the two institutions. To get to this point over the last year, we did a tremendous amount of study with people in the community, in our immediate community as well as greater Massachusetts, existing patients, people who were not patients but could be potential patients, and referring physicians. And what we learned from that was that it's sobering that still a majority of people don't have any understanding of the relationship between the Faulkner and the Brigham and the services that are available. So this really reflects a tremendous opportunity for us, both to reassure existing patients as well as to potentially attract new patients and referring physicians. Now, to make this change, there's as you could imagine, and as many of you are participating, there's a tremendous amount of changes. You can think about every single place that the logo or the name exists. And so there's been a great operational team, work group, trying to sort through all of that over the last 4 months, and we'll show you a little bit of that. We're getting into the period now, we hope to be having several celebratory events highlighting some of the history of the hospital and some of the promise going forward in September and in October. We're going to have an ice cream social as one of those events on October 1st, so you can add that to your schedule. We'll all be there scooping ice cream. We're also going to unveil a brand new history wall, hopefully in early October, which will document at this point the 110-year history of the Faulkner so that we can really celebrate the past. And then in early October, we're going to be launching a brand new redesigned advertising campaign. I'm very excited about this. I think the ads will have a completely new look and feel from what we've been doing for the last several years. And we've tried to really hone in on the message that I think you will see over the next year, that the Faulkner has both very high level quality and technical care, but we have this ability to pair it with a great heart and soul and compassion. And so that's the challenge that we're trying to convey. And we think that's in the Boston market, that's a unique offering for patients. So this is the work group that's been hard at work. If you have any questions at all about any changes related to the name or to the rebranding, you can reach out to any of these folks. I really want to thank them because it's been a huge amount of work. And that has resulted in some changes. And these are just some examples, but these are the ones that everybody in the institution really needs to know about. First of all is the ID badge change. And so it's important that everybody realize that we need to have you get a new ID by October 1st. And you can see it's a newly designed badge. It also has a barcode. And we're thinking of ways that we can take advantage of the new barcode, things like the cafeteria swipe, connection to the glucometer, health stream training or safety fair training. So I think it'll be, there's some nice perks from the new badge as well. But at some point, we have to make sure that everybody is switched over to the new badges. Secondly is all the lab coats, uniforms, security uniforms, shirts, et cetera. And so there's a plan centrally in each department to swap out over a several-week period the old with the new logo and the new name on those. But hopefully you can help us try to make sure that we're not missing anything. The signage will happen hopefully October 1st or the first part of October. That's both the big signs outside as well as the interior wayfinding signs. The things like the partner's phone directory and the email address list, folks will have to get used to this change. So if you're going to page somebody under a Faulkner or FH group page list, that will now be a BWFH list. Same with your using an email list. It won't be FH, but it'll be BWFH. So that'll take a little bit getting used to. You can imagine IS systems, it's a huge challenge. So all the systems and all the different screens, we tried to be vigilant in identifying what needed to be updated. And already IS has changed hundreds of existing reports, and they're going to be doing even more in the next 2 weeks. But after October 1st, if you still see things that are out there with the old name and the logo, we'll need to know about that so we can continue to address them. We're particularly prioritizing those things that are touching patients and referring physicians, and then making less urgent the things that are just administrative or completely internal. And then finally, think about everything that's printed throughout the institution. All the medical record forms, all the patient education materials, marketing, et cetera. So we're trying to address that centrally through Workflow One. So they're working with us to make sure as those things get reproduced, it's being updated. But we know that a lot of people have things stashed away on their H drives or shared drives or their desktops or their laptops or whatever. So we need everybody to make sure that their local materials are getting updated as well. And then finally, if you have any marketing material in your departments or patient education materials, we want to be making sure that we update those. So that's work with either Kara Marcus or with David Goldberg over the next 3 months. There's a lot of resources on the brand new, newly launched, redesigned Faulkner 411. Hopefully, if you haven't seen it yet, check it out. Liz and Kevin and David have done a great job on this transition. So on this site, there's currently a feature about the name change. There are things like a frequently asked question document. There's a telephone script, how to answer the phone, how to change your voice message. If you have things that go to patients in terms of letters or results, a couple sentences around how you can help describe the name change for the hospital so there's not any confusion going forward. So please take advantage of this and see if there's things that might be of use. Just one slide on the IT, and very importantly over the last, I think, 3 months, Partners has made a major decision, and that is to move to one single common IS system, both on the clinical side as well as the administration and finance systems. And so it will be one system across the entire Partners enterprise over the next 5 years. Even more exciting is that the Brigham and the Faulkner and the Dana-Farber have agreed to be the first pilot family or the institution to go live. So that puts us potentially going live, if everything goes well, as early as 2015. So about 2.5 years or so from now. And so you'll be hearing a lot more about this, and there's a ton of work that will start as early as this fall as we think about understanding current systems and processes and how we might build that into a partners-wide system. But this is very exciting because this finally addresses our big barrier of the two institutions being on separate platforms. And for patients and providers, it was a huge disconnect. And so that's the intent of this, is to show that there will be one patient record that exists across the entire system for the continuum. And then finally, we wanted to end with some updates on the employee satisfaction survey and work. We were thrilled that we got responses from so many of you over this in April and May, and 1,041 employees responded. This has been a great growth in response, and I think it shows testament that we are really using the survey and we take it seriously. This slide illustrates some of the highlights of the things that were very strong in terms of our performance. I think this is really great. It's a lot of very positive feedback about quality of care, the patient safety environment, and how we take the patient-family experience and patient satisfaction very seriously. And so that is a great starting point in terms of the culture and what we hold to be very important. As I mentioned, I think there's great validation that the survey information has been used in the past for improvement, and there's belief that this survey will be used to make a further improvement. Employee confidence in senior leadership, and this is great given the amount of change that has occurred over the last year, so we were happy to see that. There was a specific question on the past surveys around necessary tools and resources to do your job. And we've continued to see some incremental increase in that over the last couple of surveys. And then finally, this is the first time that we've been able to roll staff satisfaction detail in this amount of detail down to every single work unit in the hospital, so 60 or 70 different departments. And what's encouraging is that the questions that reflect readiness at that work unit level were very positive in over 90% of the cases. So it suggests that we're set up good to take the data all the way back to the departments, have discussions about it, and then start to think about a few things that we can make better. So what were the areas that we got feedback on that we need to work on? Not a surprise necessarily to folks. Top of the list was pay and benefits. Pay and benefits is always the top of the list, probably in terms of any employee satisfaction survey. But we think that the scores here were lower than benchmarks against other similar institutions. So we've already initiated both a market assessment against the local Boston and Partners community hospitals, as well as a benefits assessment, particularly around the other partners institutions, just so that we can understand current state, both on the salary side and the benefit structure. So we're taking that very seriously. The second opportunity was around performance management. This is both, do we do enough to celebrate and recognize good performance, and do we still tolerate poor performance? And there's, I think, an opportunity on both ends of that. So we've already started to do some brainstorming around things that we can change to address that. We were a little surprised that there was feedback that the hospital contributions to the community scored lower than we would have hoped. I think there's a lot of things that the hospital is doing and that many employees are doing themselves in the community. So we want to understand this more, and then we also want to focus on communicating the good work and the good programs that we do have over the coming months. And then finally, some opportunity around career development opportunities, and that's probably both some central strategies as well as in certain departments, do we have the right kind of career ladders or career advancement opportunities? So where we are in the schedule, essentially, we got the results back in June. We shared the department level results with the managers in July and had some training opportunities about how to take the results back to staff. In August and September, in the staff meetings, you should be hearing a little bit about the hospital results, but also about your own departmental results. And in those meetings, then starting to have some discussion or some brainstorming about what are the one or two things that we could work on locally to try to address staff engagement. And so we're very excited that I think it's actively happening in many of the departments. And then we hope that folks are trying out some new things as early as this month or in the month of October. And then finally, the slide that everybody waits for, the wage and salary and benefits. And this year, we're very excited that we can announce a couple new things versus prior years. We are this year continuing the 2% across the board salary increase. And for us, that's effective April 1st of 2013. But this year, for the first time, we're going to be implementing a short-term disability for all employees as a base core benefit. And as I'll show you to date, that's been an employee paid benefit. And then associated with that are some enhancements to the long-term disability and retirements. I'll come back to that in a second. So just to ground everybody around short-term disability, this is our current plan characteristics, and this is what we're moving forward to January 1st. So as I said, right now it's just an optional program for all benefits eligible employees. The core benefit, it will now become a core benefit. It's currently paid by the employee, and we will now be paying for that benefit for all staff. The current program is set up so that there's an optional either 20, 40, or 60-day waiting period for short-term to kick in. Our program will now have a 14-day or two-week calendars elimination period. And during that period, folks can use their earned time or benefit time. The current plan pays 60% of base up to 180 days out. The new plan will pay 60% of base with an option to buy up to 75% of coverage. The current max is $500 a week, and the new plan moves to $2,500 max. And the long-term disability currently travels with this, so it kicks in at 180 days. And because we're changing short-term to go out to 90 days, long-term disability will now kick in at 90 days. And currently we cannot supplement with earned time, and we'll be able to move, and you can supplement the salary with the earned time. So hopefully this next graphic shows you how this works. So if you have an injury or an issue, a medical issue that starts the short-term disability process, this is the 2-week waiting period. during which time folks can use their earned time for salary coverage. After the 2-week period, short-term disability then kicks in at a 60% salary level. This is the option for an employee to buy up to 75% of salary. And then in either case, your earned time can be used to get up to 100% salary. And then finally, at the 90-day period, we switch over to long-term disability, which currently is at 60%. And if you have the earned time bank or capability, you could use earned time to supplement. I would say that an important thing is as we move to this being a core benefit, and currently over 600 people do opt for this and pay for this benefit themselves. As we now pay for that, I would really encourage people to think about buying the long-term disability. I think from a personal income protection, it would be really advised that if you need it, if you're dependent on your income, to really make sure that you do that. And maybe use the dollars that you were using for short-term disability and now opt into the long-term disability, which we know that there's fewer number that people that do that. And then just going back to a few other things, the long-term disability we mentioned, it will move to 90 days. The maximum for that program will also be increased from $5,000 to $10,000 per month. And we're glad to say that the premium cost for that program is not going to change, even though it's going to be available sooner with a higher max. And then finally, I'm not going to get into this today, but you will be receiving over the next month, for anybody that opts into the 403B retirement program, this is the optional program where if you contribute at least 2%, then the hospital does a matching contribution. We're going to be making some enhancements to that program, better administration and reporting. We think a better set of options for how you invest your money. And so we really encourage you to look at that. And if you haven't taken advantage of it, think about starting to participate, because it certainly is. It's a great benefit, and you should try to figure out if there's a way that you can participate. So I'm going to end there, and I'd love to see if you guys have any questions. Yes?
What ITT vendor did you choose?
We ended up going with Epic, and both Neil and I were on the selection process, and I would say that there was a very thorough, complete process. It involved over 1,000 people from throughout partners over the course of the year looking at Epic versus 1 or 2 other options. Epic is emerging as the, I would say the majority of academic medical centers and larger community hospitals are using Epic versus the others. So we were validated that it has been implemented at complex places and complex systems successfully. We're pretty positive. It's certainly not a panacea. It doesn't come with all the bells and whistles that, because we've been doing our own internal development, at least within partners or Brigham, we're going to have to wean ourselves off of being able to have the perfect system versus having a system that might be a little less perfect, but it's actually connected and integrated across all the different facilities. I think that will be a huge benefit and payoff. Yes?
Previously, with the short-term care, you had to apply for it and be approved. So does this mean everyone's approved across the board?
No. It will work the same way. This is administered by the short-term benefit program. It just means that everybody will be in the program, but the process of actually getting approved for short-term disability and then managing your time will be the same. It's still a managed process. Other questions? Any questions about the branding, name changes? Yes, Alex.
I have a question about the health benefits. Are they going to be changing this year?
No. If you remember last year, we went through the transition of moving to the Partners Limited Network. And if you selected that, or if you used that limited network, you have lower copays and lower coinsurance. And so essentially, we're not making any changes to the health plan this year. Laura had to step out. I don't know if the cost is exactly the same. I'm not aware that it's going up substantially, but
Yeah, it should be normal inflationary increases on it. It won't be anything, it won't be a substantial increase
Yep.
on the partners' plans.
Yep.
What about parking, Michael? Could you clarify there was a slide in here on parking, and just clarify the rules on the open lot out back, because I've seen the tow truck out there,
Yes.
and I'd rather,
So everybody has assigned parking, everybody's supposed to have a sticker on their car that tells them where to park. If you are found parking in a spot other than where you are authorized to park, you'll receive a ticket. If you receive a ticket 3 times, you'll be towed. And you have seen a tow truck, because we have started enforcing it. We're trying to accommodate everybody. What's most important is that our patients have premium parking and that they have a spot. So that's the rules. If you're unclear from looking at your sticker where you should be parking, Faulkner 411 has the policy, which I think is pretty clear. You can always call Chris Sargent or talk to your manager. Is that right?
thank you.
Yes.
Will the blue sticker on our windows change that says Faulkner?
Not in the short term.
We, go ahead, sir.
Going forward, we will be having new stickers, so Chris Sargent is working on that.
But we're not going to go around to all the cars and take off the existing stickers.
Not by October.
Unless we have a volunteer. Yeah. Yes, in the back.
When you were mentioning how the physicians work for currently Faulkner, but there'll be a process where there's one, I forget the exact word you used.
Credentialing process?
Yes, for both. Will then all the physicians here be under the Partners Plus umbrella for our health insurance purposes?
Susan, you want to take that question too?
Sure. So we do not make the decision on which providers would be covered under Partners Plus. It's a Blue Cross product, and the way the product was designed was to make preferred status for everybody in the Partners network. That's why we were able to get the rates that we get. So we did recognize partway through the year that there were some physicians who are not employed within the Partners network, who really are still critical to the care of our employees and their families in our communities and on our campus. So we actually have been working with Partners HR and Blue Cross to try and get some providers who work on this campus to be considered exceptions and to get their preferred status. So at the end of the day, it's not our decision, it's Blue Cross's decision. We think we've made a good case for why some of them should be. Either they're the only ones who provide that specialty here, or they're integral to our programs. So it's, like I said, it's out of our control, but we have tried to address that.
Thank you.
It's a great question. And just to clarify about the credentialing, and so when we say that there's a joint credentialing, it doesn't mean that all the Faulkner physicians are coming into the Brigham Physician Organization. So just like today, we credential both Brigham physicians and we credential private staff. That will continue. It's just the process by which they go through in terms of the usual credentialing will be a unified single process, the same application, the same categories, the same steps, and the same timeline. And so an individual physician can choose to just be credentialed at the Faulkner, just to be credentialed at the Brigham, or if it's relevant, and we only want this to be if it's actually relevant, that they then can be, and they're practicing at both places, they can be credentialed at both places. So that's a great question. Other questions? Yes, sorry.
Yes, I am part of the Partners Network, or is that separate?
Yes.
They're not part of the Partners network per se, but they are considered the preferred ophthalmology provider for the Partners Plus plan, if that's what you mean.
Yes, because my ophthalmologist is on Mass Eye and Ear, but when I went to go, he's not on, in other words, he's not on the list.
Then I think that in cases like that, you should, I think in all of our plan information, there's contact information at Blue Cross Blue Shield that you should be able to call and ask the question. Because that may be an oversight. As I understand it, Mass Eye and Ear is the preferred ophthalmology provider for the Partners Plus insurance plan.
Similar to Dana-Farber or Children's Hospitals are kind of included in the network, the preferred network, even though they're not part of the Partners system. Other questions? Okay, well, I really appreciate your attendance today. If you could help pass on some of these key messages, it'd be really great. Thank you.